Thank you, David. Good morning. Thank you for taking the time. You see the affiliation on the slide is Center for Integrated Diagnostics. In our group, we integrate new diagnostic tools into clinical practice all the way to full clinical integration, including payer negotiations. So I want to start here is illustrating a compelling clinical problem. Now, women who self-examine and or are identified as having a breast lesion on mammography undergo a difficult decision tree, one of which is to get a biopsy to delineate the nature of the underlying lesion. Now, when that is performed, some patients will have a benign lesion and surveillance and other treatment is necessary. Some have cancer and an appropriate surgery is necessary. However, a small but sizable fraction of women will have a certain subset of lesions referred to as high risk. The term derives from a definitive statistical increased risk for upgrading if that lesion is resected. Now, portrayed on this slide is a set of high-risk lesions that affect approximately 200,000 women in the US per year. Now, after this workup is performed and a surgical resection is performed, you see in a training and validation set recently published by Bal et al., including Connie Lehman and Regina Barzilay, that about 11%, let's just round that completely wrong, up to 20% of patients are potentially upgraded to a more severe lesion. Now, that is the reason why the surgery and the resection is performed. However, one could word the problem also in the reverse fashion and say 80% of surgeries are at least potentially able to be prevented or could be considered, in parentheses, unnecessary. Now, we asked the following question. By taking in a lot of the electronic medical record data as well as, hopefully soon, the histology at the time of biopsy, can we predict which of the surgeries are necessary or not? Now, the algorithm has been published as seen here. It's also in the documentation that you received in your booklet. I purposefully did not put any accuracy, precision, or sensitivity or ROC curves in here, because the compelling clinical problem that I want to illustrate is, on the one hand, how to integrate this into clinical practice. So you heard a lot about these algorithms, and that's illustrated on this slide, basically starting with the data all the way to a deployment in red, and then the actual deployment and how to integrate it clinically is one of the elements that we have a lot of experience with, and I wanted to briefly show you how that could look like. So again, the time scale from self-examination to the biopsy and a pathology report shown on the bottom left is temporarily disconnected with the actual resection and another pathology report saying what the actual resection was. And what we plan to implement is, shown on the bottom left, an ML prediction score ranging from 0, low risk for an upgrading, to 1, a high risk for upgrading. And this could be one additional item on the pathology report that informs the clinician, surgeon, or oncologist whether and how to proceed in the workup of a patient. This could be considered relatively straightforward, but what's necessary and what's preventing us from implementing this today? And I think we found a very compelling solution for that. Now, the tricky part here is the generation of the data for the machine learning, and I want to illustrate why that's such a problem in digital pathology. So to incorporate the slides and all the information, it is not just the one-time research data set that you have to accumulate and then annotate and then present. It is that you have to continue to be able to do that in clinical practice. Now, when looking at what is to the left of the data store, and in this particular series, we wanted to do this for about 1,000 slides, there's 2 or 3 elements that are necessary. Number one is, up until recently, there was no common data format for digital pathology. While the DICOM standard is the de facto standard for medical imaging, it hasn't been implemented for pathology. However, we recently accomplished that, and the reference is provided there, and I think Marcus Herrmann is one of the first authors. This was a partners level radiology as well as pathology-wide project, and the Center for Clinical Data Science has helped tremendously. The problem is, however, slightly different. When you look all the way on the left, the archiving of slides, the slide review, the laboratory information management system, and the electronic health record are completely disconnected from that information being available to pathologists. In other words, the cancer diagnosis lives as a Unicode text in the electronic record. However, the pixel data are, as far as we are right now in 2019, not part of any of these data silos. So to disrupt this, we have to retrieve the slides, and this is a manual labor to scan them and then actually integrate them in an efficient workflow. At the same time, the metadata, so the non-real world entities of diagnosis and where these attributes live, have to be integrated as well. Now, DICOM provides the framework, but the integration of metadata and pixel data is currently a big problem. Now, what that would look like, we outline as a blueprint. So shown on the bottom left is the electronic as well as the real-world data streams that have to be aligned, meaning the metadata have to be read from the LIMS system and integrated into the DICOM file, as well as the real-world slide scanning, filing, and archiving have to be accomplished. A prototype would be that alignment, and these can easily be scaled, as illustrated on the bottom right. Now, when looking at the performance of such a system, it's shown here on the left as individual batches of 10 slides that are integrated within about an hour. Now note, this is not just a scanning component, this is also including the extraction of the relevant metadata from the medical record. We are now at about 30% completion of this data set. Now what's the dream here? If we just assume that of these 200,000 high-risk lesions, we want to estimate what a potential market size would be. If we would only use a conservative estimate of 10% reduction of unnecessary surgeries, so that's only an eighth of what's potentially possible, that would be 20,000 women, and then the cost of a stage 1 resection, this is also a conservative estimate, the market size would be approximately $1.4 billion. And what we're currently attempting is to integrate this solution as a combination of pixel and metadata via established healthcare integrators. Now, in summary, the training of AI models, in particular in digital pathology, requires digitization of slides, or simply put, access to the pixel and metadata. The clinical integration of AI will, however, continue to rely on a production line pixel and metadata acquisition. This is not going to go away even if the models are established. The US market, which I outlined, is billions of slides wide. Just to give you some numbers here, at MGH we produce about 2,000 slides a day. In the partner system, about 1.4 million slides per year. And if we just take 4 academic medical centers that we collaborated with, for example, for one of our FDA trials for implementing one of the scanning systems, we're talking millions of slides per year. This is a huge data storage and slide scanning effort. What I think we accomplished is that we turned machine learning data acquisition into a solvable production line problem. And again, we're looking for funding for the production line. If someone's interested, some of the representatives from the team shown here will be outside, and we're happy to talk to you. Thank you very much.